What are juvenile bunions? As the name implies, it is a bunion deformity that occurs in children, generally teenagers. Most people associate bunion deformity with a condition that occurs in older individuals. In bunions, developing in children, the patient generally exhibits a hypermobile or flatfoot deformity where there is too much pronation, which creates excessive motion in the foot and results in a splaying or spreading of the metatarsals. Seen in most cases of juvenile bunions is a metatarsus primus varus where the first metatarsal bone is much further from the second metatarsal compared to the relationship of the second, third, fourth, and fifth metatarsal bones. This enlarged angle has forced the first metatarsal bone to move away from the other metatarsal bones as a result of the hypermobility exhibited by the patient. As the first metatarsal bone moves in one direction, the big toe begins to move in the opposite direction, toward the second toe, and what you end up with is a protrusion on the inside of the foot that is subject to excessive shoe pressure, but probably even more important, an abnormal alignment between the big toe and the first metatarsal. This abnormal alignment will result in a premature erosion of the cartilage of this joint and then ultimately pain. Treatment of juvenile bunions. Conservative care. Although unsightly, in many cases they are painless deformities. In those situations our goal is to try and prevent them from getting worse. In order to accomplish that we have to control the hypermobility that I mentioned earlier. If we can control the excessive motion occurring in the foot, we can cut down on the forces that are aggravating and causing the bunion to form. We accomplish that through the use of orthotics. Not only do we cut down on the hypermobility, but we also create better alignment of the joint in an effort to cut down on the erosion of the joint. There are a few things worth mentioning about orthotics as it relates to the juvenile bunion. If the child has not finished growing, he or she is probably going to outgrow the orthotics in less than 2 years, which will require a new pair. It is fairly safe to say that the patient will require orthotics throughout their adult life, as the tendency for hypermobility exists even in adulthood. To get the maximum amount of good out of an orthotic, the patient has to wear them as much as possible. A scenario where the child wears them all day at school, then comes home and takes off their shoes and runs around barefoot for another 6 to 7 hours kind of defeats the whole purpose. As soon as you remove the orthotic, the foot returns to its normal position of hypermobility and the forces that are aggravating the bunion formation are back in play. Orthotics work like eyeglasses. When you wear them, they do the job that they are intended to do. When you remove them, everything reverts back to the way it was. Unfortunately, not all juvenile bunions are painless. In the instances where there is a small amount of discomfort, orthotics and modification of the type of shoe worn by the patient may help alleviate the pain. For occasional pain, Advil or a leave taken short-term can be very helpful. Surgical correction. In those situations where conservative measures have failed, you have to consider surgical intervention. The problem here is that you are having a procedure done that has a relatively high failure rate. I have seen statistics stating a failure rate of 60%. Even if the initial procedure is successful, you are now hoping that the procedure will last the next 60 to 70 years, a probability I find to be quite low. So, even with a successful procedure, there is a relatively high probability that the patient may need additional surgery somewhere down the road. To further complicate the situation, most juvenile bunions cannot be corrected with simple bunionectomies where just the enlarged bump is removed. The issue of the metatarsus primus varus has to be addressed in order to get better alignment of the big toe joint. To accomplish this, depending on how bad the deformity is, either an osteotomy, the surgical breaking and realigning of bone, will have to be performed, or a fusion of the base of the first metatarsal to the bone behind it, cuneiform bone, will be necessary in order to stabilize the first metatarsal. The right choice may not be easy to come by. My feeling is that surgical intervention should be considered only on juvenile bunion deformities that hurt a lot on a regular basis. These are bunions that have not responded at all to conservative care. It should also be noted that no matter how much pain the child may be in, the procedure cannot be performed until their growth plates are closed and the bones are finished growing. Although a second opinion is always indicated prior to any surgery, I think this is one situation where it should be mandatory. Read the complete article at www.foot-explained.com/juvenile_bunions.html.